النهارده ان شاء الله هنتكلم على التوبيك هو مش كومن قوي بس ان شاء الله يبقى انترستد في التيتشنج. هنتكلم على retroperitoneal tumors. Firstly, we will discuss the surgical anatomy of the retroperitoneum. We mean that by the retroperitoneum is a complex potential space with multiple vital structures bounded anteriorly by the peritoneum, ipsilateral colon, mesocolon, pancreas, liver, and stomach. The posterior margins are large, composed of the psoas, quadratus lumborum muscle, transverse abdominal and iliacus muscles, but depending on the tumor location and size may be formed by the diaphragm, ipsilateral kidney, ureter, and gonadal vessels. Similarly, the medial boundaries may include the spine, paraspinatus muscles, the inferior vena cava for the right-sided tumors and the aorta for the left-sided tumors. The lateral margin is formed by the lateral abdominal musculature, and depending on the tumor location, it may include the kidneys and the colon. Superiorly, retroperitoneal tumors may be in contact with the diaphragm, the right lobe of the liver, the duodenum, the pancreas, or the spleen. The inferior margin may relate to the iliopsoas muscle, the femoral nerve, the iliac vessels, or the pelvic side wall. The retroperitoneum can host a wide spectrum of pathologies, including a variety of rare benign tumors and malignant neoplasms that can be either primary or metastatic lesions. Malignant tumors of the retroperitoneum occur 4 times more frequently than benign lesions. Sarcomas comprise a third of the retroperitoneal tumors. Sarcomas constitute a heterogeneous group of rare solid tumors of mesenchymal cell origin with distinct clinical and pathological features. They are divided into 2 broad categories depending on the cell of origin or the tissue of origin, the soft tissue sarcomas and the bone sarcomas. And here we will discuss only the soft tissue sarcomas and not the bone sarcoma. Sarcomas collectively account for approximately 1% of all adult malignancies and 15% of pediatric malignancies. The true incidence of soft tissue sarcoma is underestimated, especially because a large proportion of patients with gastrointestinal tumors may not have been included in tumor registry database before 2001. The most common subtypes of soft tissue sarcomas in general in any site of the body are undifferentiated pleomorphic sarcoma, gastrointestinal stromal tumors, liposarcoma, leiomyosarcoma, synovial sarcoma, and malignant peripheral nerve sheath tumors. The anatomic site of the primary disease represents an important variable that influences the treatment and outcome, as extremities represent 43% of cases, trunk 10% of cases, visceral sarcomas in 19% of cases, retroperitoneal in 15%, head and neck in 9% of cases. Approximately 80% of the neoplasms that arise within the retroperitoneum are malignant. Not all are sarcomas, but maybe malignant lymph nodes, malignant metastatic disease. Furthermore, the majority of patients who present with a primary retroperitoneal, extravesical, unifocal soft tissue mass will be found to have sarcoma. Retroperitoneal sarcoma represents only a third of the retroperitoneal tumors. In adults, the most common histologic subtypes of retroperitoneal soft tissue sarcomas are liposarcomas, representing 70% of cases of retroperitoneal sarcoma, followed by leiomyosarcoma, representing 15% of cases, followed by pleomorphic undifferentiated sarcoma and malignant fibrous histiocytoma. A variety of other histologic types may be observed, but they are much less common in the retroperitoneum than in other primary sites. As the most common type, histologic type of retroperitoneal sarcoma is liposarcoma. We have three different types of liposarcoma. The well-differentiated liposarcoma, which is typically, histologically, pathologically, and genotypically like the atypical lipoma, which is present in the extremities. But the differences between both, that the atypical lipoma in the extremities is well circumscribed and can be excised safely with a low rate of recurrence because there is less invasion to the surrounding structures. The well-differentiated liposarcoma, which is present in the retroperitoneum, it has no capsule, has a very high rate of recurrence in spite of being well differentiated. The second type is a dedifferentiated liposarcoma. We have in the dedifferentiated liposarcoma two types of pathologies. We have two components, the lipomatous component, which is a well-differentiated, similar to the well-differentiated liposarcoma, and a high-grade type in between, which is the fibrous element in between is a high-grade sarcoma. The third type is a pleomorphic liposarcoma, which is a very poorly differentiated sarcoma, liposarcoma, with a very high rate of recurrence, has a high susceptibility of distant metastasis, especially to the lungs and to the liver, with difficulty in excision because of invasion to the surrounding structures and a high rate of recurrence. The second most common type of retroperitoneal sarcoma is the leiomyosarcoma. It is a sarcoma showing smooth muscle differentiation that is based on a combination of histomorphology and immunophenotypic expression. In contrast to other sarcomas, the use of core needle biopsy specimens in primary diagnosis of leiomyosarcoma is increasingly recognized to correlate poorly with the final tumor grade in resection specimens, and this may have important implication in treatment. So if we diagnose a patient with leiomyosarcoma by radiological investigation, we go directly for excision without biopsy. The other less common types of sarcoma are malignant peripheral nerve sheath tumors. These are tumors which either originating from peripheral nerve sheath cells or have a differentiation towards peripheral nerve sheath cells. They are either sporadic or as a component of neurofibromatosis type 1. The poor prognosis is associated with higher size, larger size of the tumor, and association with neurofibromatosis type 1 as they have a higher rate of recurrence. The symptoms depends on the nerve which is involved and the site of the tumor. Synovial sarcoma is a very aggressive type of soft tissue sarcoma related to joints. Have a high rate of recurrence and high rate of invasion. Solitary fibrous tumor, which is formerly known as hemangiopericytoma, solitary fibrous tumor ranging from benign to malignant condition with unknown behavior. It may invade locally and has a high rate of recurrence if not excised completely with adequate safety margin. Ewing and Ewing-like sarcoma, this is a disease most commonly of young adults and childhood. This is plastic small round cell tumor, and undifferentiated or unclassified sarcoma, which has no cell differentiation towards either lipomatous tissue or towards fibromatous tissue. It is unknown cell origin. Among children, the most common histologic types of retroperitoneal soft tissue sarcomas are extraskeletal Ewing sarcoma, primitive neuroectodermal tumors, alveolar rhabdomyosarcoma, and fibrosarcoma. Approximately 1/2 of retroperitoneal sarcomas are high-grade tumors, although this varies according to histology. The majority of retroperitoneal liposarcomas are low to intermediate grade types. Soft tissue sarcoma most commonly metastasize to the lungs by bloodstream, but tumors arising in the abdominal cavity either retroperitoneal or visceral, will metastasize to the liver and the peritoneum, creating a form of peritoneal sarcomatosis, which is similar to peritoneal carcinomatosis of the GIT tumors, representing an end stage of the disease. The management of soft tissue sarcoma in adult patients is addressed from perspective of the following disease subtypes. In taking decision of management, we will see the site of the tumor, either retroperitoneal or intra-abdominal soft tissue sarcomas. GIST has a different management plan. Desmoid tumors and rhabdomyosarcoma, all these subtypes have different plans of treatment. We have genetic cancer syndromes which predispose to retroperitoneal sarcoma or soft tissue sarcoma in general. The first and the most important is Lefroy syndrome, which represents a mutation in the TP53 germ line. The TP53 is the most important tumor suppressor gene in human body. When it is mutated, there will be many tumors will arise. The most common sites associated are soft tissue sarcoma, breast, gastric carcinoma. There may be colon cancer. There may be pancreatic carcinoma and prostatic carcinoma. But the most common sites of malignancy in Lefroy syndrome are the breast, the gastric, and soft tissue sarcoma, in addition to uterine body sarcoma. The second is Gardner syndrome, which is associated with the FAB, the familial adenomatous polyposis coli, and this is associated with desmoid tumors. And if we found a desmoid tumor, multiple desmoids, extra-abdominal desmoid, which is most commonly present in the area of the shoulder girdle, or a visceral desmoid tumor, we will suspect that this patient has multiple polyposis coli, and we have to investigate for this by colonoscopy or by CT enterocolonography to assess the condition of the patient and to assess the problem in these patients. A third syndrome is a Carnes-Trachis syndrome associated with gastric stromal sarcoma and paragangliomas, and Carnes triad, which associated with, in addition to the gastric stromal sarcoma and the paraganglioma, there will be a pulmonary chondromas. When we see a patient with a retroperitoneal tumor or suspected retroperitoneal tumor, we have to do some work up. First, as in a general case in surgery, we have to take a very careful history and physical examination. The history of this patient will give a long history of increasing the abdominal distension. This is the main complaint. In some cases, there may be pain, which is associated with either nerve compression. There may be necrosis in the tumor causing severe agonizing pain, or there may be compression on the vessels and veins causing edema of the lower limb, or even there may be ischemia of the lower limb due to invasion of the vascular supply to the lower limb. The second, we have to do some radiological investigations. As any patient, simply we will go for ultrasound, but if we suspect a retroperitoneal from that retroperitoneal tumor from the start, we can go directly to contrast enhanced CT computerized tomography of the abdomen and pelvis. The first is to do for the abdomen and pelvis to assess the site of the tumor, the relation to the surrounding structure, the pathological criteria of the tumor also can be gained from the CT, as the most common is to be a lipomatous origin, and lipomas by liposarcoma can give us can be well differentiated, in which the lipomatous tissue is very clear. There may be a dedifferentiated liposarcoma with a soft tissue enhancement inside the lipomatous tissue. Also, the CT will show the invasion to the more important structures and will assess the resectability, as we will say later on, the criteria of resectability and unresectability of the tumor. If we diagnose a patient by CT, by CT to be a retroperitoneal sarcoma or suspecting retroperitoneal sarcoma, we have to go directly for CT of the chest, because if we have a metastatic deposits in the lung, as it is the most common site of metastasis, this case is inoperable, it is incurable. So we have to give the patient palliative treatment. MRI may add some data if I have a case in of a sarcoma extending to the anterior abdominal muscle to assess the magnitude of the problem. This picture shows a CT. This one is a clear lipomatous tissue with a huge retroperitoneal tumor pushing the viscera to both sides. The second one, we have a soft tissue lesion with a lipomatous lesion. This soft tissue lesion, lipomatous lesion, is a differentiated liposarcoma, well-differentiated component here. Another type of tumor is that one, which is a leiomyoma of the inferior vena cava. As you see, this is the inferior vena cava in between, inside the tumor with compressed and narrowed lumen. By CT, we can assess the criteria of unresectability, as some tumors may be resectable by radiology, but intraoperatively will be unresectable. So we have to assess the criteria of unresectability prior to taking the decision of going to explore the patient. The first is extensive vascular involvement. Extensive vascular involvement of the major vasculature of the abdominal retroperitoneum is the aorta and IVC and the iliac vessels. Although the involvement of the IVC and the iliac veins are considered not absolute contraindication for a resection, as they can be replaced by interposition grafts. The peritoneal implants, as we said, that this is an end stage of the disease. Peritoneal implants means a peritoneal sarcomatosis, which is similar to peritoneal carcinomatosis. The presence of distant metastasis, either liver deposits or lung deposits by CT. Involvement of the root of the mesentery, as if the root of the mesentery involved the superior mesenteric vessels, mainly the artery will be involved, and by dissecting these vessels, the intestine will be necrotic within few minutes. So it is a character of unresectability. The spinal cord involvement, as the spinal cord, there will be the spinal nerves originating from the foramina of the spinal cord of the vertebral column. So extension of the tumor inside this foramina is an important character of being unresectable if the spinal cord is involved. Can we take a biopsy from a retroperitoneal tumor, and what type of biopsy? Biopsy is not necessarily required. If we diagnose a patient with retroperitoneal sarcoma, we can go directly for assessment and resection. But biopsy is indicated and is very important if we suspecting a disease other than retroperitoneal sarcoma, or if we suspect that the patient has rhabdomyosarcoma, because the management is different. So if we have a patient with a retroperitoneal tumor and we suspect a lymphoma, and there are no other lymph nodes inside, all over the body, after complete physical examination and radiological investigation, we can go directly for core needle biopsy. The best is to do a guided core needle biopsy, because the larger size of the tumor will cause necrosis, and if we take a blind biopsy, we may injure a structure which is in between the tumor and the anterior abdominal wall, or we may take a biopsy from a necrotic area which will not give a data about the tumor. Sometimes if we take a biopsy, sometimes we found that the patient has a well-differentiated tumor, but we missed a poorly differentiated area. Patients with personal family history suggesting of genetic disorders like Ray-Fromeny or Gardner, we have to do a genetic assessment and genetic counseling for the other members of the family. Retroperitoneal sarcomas are staging using the same T&M staging used for extremity soft tissue sarcomas. However, the ability of the T&M staging system to discriminate outcome is limited. Several studies have found no prognostic rule for tumor size in the retroperitoneal sarcoma, as most of the cases are represented with a huge size. Given the importance of histologic grade and the resection margins in the prognosis of retroperitoneal soft tissue sarcoma, alternative staging systems has been proposed that incorporates these features as well as the presence or absence of metastatic disease. However, this staging system is not widely used. This is a T&M as any T&M staging, but TX means that the primary tumor cannot be assessed. T0, no evidence of a primary tumor. T1, tumor is less than 5 centimeter, greatest dimension. T2, tumor more than 5 but less or equal to 10 centimeter in greatest dimensions. T3, tumors more than 10 but equal or less than 15 centimeter in greatest dimension. And T4 if the tumor is more than 15 centimeters. Lymph nodes N0 or N1, either presence or absence of lymph nodes. Distant metastasis M0 or M1, answer the presence or absence of distant metastasis. The grade is incorporated in the staging system of the T&M staging system of the sarcomas as GX grade cannot be assessed if the tumor is excised and spent away. Grade 1, grade 2, and grade 3 according to the cell or the differentiation towards the cell of origin. This is collectively the staging system as every stage. Stage 1 is divided into stage 1A and 1B. Stage 2, stage 3A and 3B, and stage 4 if the presence of any metastasis in spite of the site and the size of the tumor and the presence or absence of any N or any grade. This is another staging system which is applied after resection of the tumor. At the Deutsche Memorial Sloan Kettering Cancer Center classification system for retroperitoneal soft tissue sarcoma, stage 1, the tumor is low grade with complete resection and no metastasis. Stage 2, high grade tumor with complete resection and no metastasis. Stage 3, any grade with incomplete resection and no metastasis. Stage 4, any grade, any resection within the presence of distant metastasis. After assessing the patient, we will go directly for treatment. Treating these patients, the most important is to excise the tumor completely without residual tumor tissue. So surgical resection has traditionally been the only potential curative treatment for a localized retroperitoneal soft tissue sarcoma. And the ability to perform a complete surgical resection at the time of initial presentation is the most important prognostic factor for survival. So we have to locate a good surgeon specialized in retroperitoneal sarcoma excision to excise the tumor completely without resection, without residual tumor tissue. The primary oncologic goal is complete resection with microscopically negative margins. So we have to reach the R0 resection. R0 resection means that after complete excision of the tumor, there is no residual microscopic tumor tissue by pathological examination. However, the larger size of the most retroperitoneal tumors give us the issue that we may excise the tumor completely. But on microscopic examination, we may find that there is residual microscopic tissue. This is R1 resection. In clinical practice, many resections are grossly complete, but with microscopically positive margin. So what will we do if I have a microscopically positive margin? If I have a microscopically positive margin, I have to do resection. So I have to go again for surgery and re-resect the site of suspected to be R1 resection. But in most of the cases, this is not complete. So some cases we don't have the ability or have the facility to go again for surgery. So in these cases we will give the patient radiotherapy, but intraoperatively I have to mark the area in which I may suspect there may be a residual tumor in this area, residual microscopic tumor. To allow complete surgical resection with adequate margin, so we have to resect adjacent organs, such as the small bowel, the colon, or kidneys is often required to achieve a complete resection, and bowel preparation and the evaluation of the kidney function should be performed prior to exploration. Liberal en bloc resection of adjacent viscera may allow subset of patients to achieve wide macroscopically negative surgical margins who might otherwise have been considered be unresectable. There is no rule and no survival benefit of incomplete resection of retroperitoneal sarcomas. So either to go for complete resection or don't open the patient at all. So all or none rule, to resect or not to resect. There is no rule of debulking in these patients. Additional treatment is the adjunctive radiotherapy. In contrast to soft tissue sarcoma of the extremities, in which the most common site of first recurrence is distant site, the most common site of failure in retroperitoneal tumors is local recurrence. So radiotherapy can be administered following resection. However, increasing preoperatively, there is a higher role for preoperative radiotherapy for high grade or large size tumors. It is often difficult to deliver post-operative radiotherapy. This is why, because we remove a large size of the tumor, displacing the viscera away, and after resection of this large size the tumor, all the intestine and the colon will go to locate in the site of the tumor. So delivery of a higher dose of radiation will irradiate the intestine, and the higher dose will involve the kidney with a very difficult side effects and complications of radiotherapy. So preoperative radiotherapy may be an option for these large size and high grade tumors. In the post-operative settings, radiation doses to the tumor bed are often limited by large field size and the proximity and tolerance of the surrounding radiosensitive normal structures such as the liver and bowel. In fact, many multidisciplinary sarcoma groups do not routinely offer post-operative radiotherapy to patients with resected retroperitoneal sarcoma because of the significant concerns about the narrow therapeutic ratio. So the rule of preoperative radiotherapy, the delivery of radiotherapy preoperative to surgery with or without intraoperative radiotherapy at the time of resection may permit the safe delivery of a higher radiotherapy dose than are possible in the post-operative settings. There are several theoretical advantages of preoperative as compared to post-operative radiotherapy for retroperitoneal sarcomas. The main advantage of preoperative radiotherapy is that the gross tumor volume can be precisely defined. So I can assess the whole tumor volume for radiation treatment planning, allowing accurate targeting of radiation volume around the tumor. The tumor itself can act to displace the bowel away from the tumor, preventing the higher dose of radiation to reach the bowel, which will complicate if it be irradiated by radiation enteritis with multiple fistulae later on. Higher radiotherapy doses can be delivered to the actual tumor field, since the bowel adhesions to the tumor are less likely compared to post-operative settings. The risk of intraperitoneal tumor dissemination at the time of the operation may be reduced by preoperative radiotherapy, as if the tumor is fragile and all the retroperitoneal malignancies are not encapsulated. If the tumor is opened intraoperatively, there is a higher risk for local recurrence and a higher risk for retroperitoneal peritoneal sarcomatosis. So by irradiation, there will be creation of a fibrous capsule around the tumor which prevents this dissemination. In addition, this capsule may improve the resectability of the tumor and changing the tumor resectability from being unresectable to resectable one by creation of the fibrous capsule around the tumor. Again, radiation is considered to be biologically more effective in the preoperative settings that will act on the active tumor tissue. These advantages may result in an improvement in the therapeutic ratio when radiotherapy is administered preoperatively than postoperatively in cases of retroperitoneal sarcomas. Retroperitoneal sarcomas have a substantially less satisfactory outcome than soft tissue sarcomas at other sites such as extremities or the trunk. Several factors contribute to the poor prognosis of retroperitoneal sarcoma and a higher rate of recurrence, including that they are presented at a large size from the start at diagnosis and anatomically situated, such as wide resection is often not achievable. Even with complete resection, retroperitoneal sarcoma, liposarcoma, tend to do worse than the extremity liposarcoma, independent of the tumor size, grade, and surgical margins. The surrounding normal tissues, liver, kidneys, gastrointestinal tract, and the spinal cord have a relatively low tolerance for radiation therapy. As a result, radiation dose levels must be kept below those typically employed for extremity soft tissue sarcomas. In contrast to extremity sarcomas, 90% of first recurrence are local. Eventually, distant metastases develop in 20 to 30%. The main sites of distant metastasis, as we said before, are the liver and the lungs. Local recurrence rates are higher with high-grade, poorly differentiated tumors, liposarcomas, histology, and in patients with positive resection margins. This is a case of retroperitoneal sarcoma. As you see here, we have a huge tumor, this one, a very huge tumor in a female patient. We took the decision to open the patient to resect this tumor because according to the criteria of resectability, it was resectable. It was not attached to the retroperitoneal, to the major vascular structures. There were no distant metastases, no peritoneal sarcomatosis, and the tumor is assessed to be resectable. This is the tumor, this is the uterus, and here we have the colon stretched over the tumor. This tumor displaces the tumor, the colon medially. It originates from the left side of the abdominal cavity. Here, to get a more a safe resection margin, we resected the tumor, the colon, which was a sigmoid colon, stretched over the tumor. Here is the tumor post-operatively. As you see, the size of the tumor is about 26 centimeters in length. And this is the pelvic cavity, which is free after resection of the tumor. Another case, this is a horrible case actually of retroperitoneal tumor. As you see, this is, all of this is a tumor displacing the viscera posteriorly, and this is the aorta. The tumor is lying over the aorta here, here again, here. Another issue in this is the left kidney here. The left kidney is involved by the tumor. The tumor encasing, surrounding completely 360 degree around the renal vessels. Here is the aorta, which is displaced to the right side by the tumor. The tumor has two components, on the right and on the left, but mainly on the left, displacing the aorta here. The tumor is reaching to the spleen, the lower pole of the spleen here. This is the abdominal distension. He was a male patient with severe abdominal distension and compression over the vessels and over the nerves. On opening the abdominal cavity, the first impression is to assess the general abdominal cavity, for as it was not present in the radiological, there was no ascites, no peritoneal sarcomatosis, and no liver metastasis. But firstly, we assess the liver. If there is metastasis, we will not resect. If there are no metastasis, we assess, we will resect. Also, this patient by CT chest prior to surgery, there was no pulmonary deposits. Here is the colon, the left colon stretched over the anterior surface of the tumor. This is part of the tumor on the left side, and this is on the right side again. We started to resect the colon. As you see here, the colon is resected, and we assess posteriorly for complete dissection of the tumor from the retroperitoneal space. Here we reached, these are the renal vessels. We reached the renal vessels from the right side, the left side of the left renal vessels. The left renal vein is here, but the kidney is embedded inside the tumor. The tumor completely surrounding the kidney with no plane of cleavage in between. Here is the colon resected, and this is the tumor. This is after completion of excision of the tumor. The size of the tumor was more than 50 centimeter in length and more than 40 centimeter in width. We excised the left colon, the left kidney. Here, another issue is that the tumor was extending into the inguinal canal from posteriorly. We excised the left testicle and spermatic cord. And this is after complete excision. This is the left renal vessels, and this is the aorta and iliac vessels. In cases of recurrent retroperitoneal sarcoma, also we have to go for resection. This is a case of liposarcoma with recurrent liposarcoma. Here, this is a small mass lying posteriorly over the vertebral column and in front of the iliacus muscle, of the psoas muscle, sorry. This is the retroperitoneal recurrent mass, and this is after complete excision with the pelvic free. Thank you.